If you're going through menopause, the chances are high that you looked into alternative or complementary therapies, especially if you've been suffering from very severe hot flashes and poor sleep. Studies have shown that up to 50 and 75% of postmenopausal women have already tried complementary alternative therapy for menopausal symptoms. And that number may be even higher among those women who've had a history of breast cancer, as they are unable to take hormone therapy. So today, we're going to talk about those alternative treatments and whether or not the evidence shows they work. I'm Dr. Naznin Jamal. I'm here to bring the medicine to you to make it make sense. If you like this content, give me a thumbs up and subscribe. This helps me build my channel. We're going to start off about how difficult and tricky the menopausal symptom research is. A lot of these trials are small, they're short term, and they don't have a controlled group or a group that is receiving the placebo treatment or therapy. And that actually limits the generalizability or even the applicability of some of these results. It's difficult to know if the improvement was just from receiving a treatment or if it was actually due to the treatment. So here's what people get tripped up by. That placebo alone did show an improvement in hot flashes in up to 50% of women. I'm going to repeat that. In studies that had a treatment arm and a placebo arm, both groups showed an improvement. So the key question is, was the improvement greater in the group that received the treatment compared to placebo? The other question we think about is, was the change meaningful for the women who were suffering from the hot flashes, and was it safe for breast cancer patients? Cognitive behavioral therapy, also known as CBT, is therapy that's based on helping people identify the triggers, the circumstances surrounding the development of the symptoms, and to identify consequences and behaviors from that. They use a skills-based approach to create practical strategies to improve the symptoms and the coping and just day-to-day functioning. Studies investigating CBT showed that the cognitive behavioral therapy did not reduce hot flash frequency, but did help with the patient's coping. It has been shown to be helpful for menopause-related insomnia and women with both hot flashes and poor sleep. In a randomized trial comparing cognitive behavioral therapy for insomnia to menopausal education, 70% of the women receiving cognitive behavioral therapy had no insomnia afterwards, compared to just 24% in the menopausal education group. CBT does improve the quality of life, but access can actually be very limited because it often requires trained providers and repeated visits. It can be done through a telehealth platform, but even that's difficult, and most insurance carriers do not pay for that. Hypnosis is surprisingly promising, but it's not ready yet for mass introduction. In one trial, hot flashes dropped by up to 57% with hypnosis compared to only 10% in the control group. That control group response is unusually low, so it does raise some questions. Before hypnosis can be widely introduced to the mass population, the technique must be standardized and provider training must be consistent. Then we've got mindfulness-based stress reduction, or also known as MBSR. And although this is very interesting, the treatment modalities have had mixed results. Mindfulness-based stress reduction did show to reduce the bother or the nuisance associated with hot flashes themselves, but these techniques did not reduce the frequency of hot flashes as measured by the researchers by using a severity score. Participants were asked to document a score giving how many hot flashes they had and how severe they were. We also have stellate ganglion blocks. A ganglion is a group of nerve cell bodies that allows us to perceive sensory information like pain, temperature, and it allows us to enact autonomic body functions such as blood pressure, tone, sweating. It aids in digestion. A block is designed to inject the ganglion with an anesthetic in an effort to reduce the sensation of the symptom we are trying to avoid, such as pain in most cases. But in this case, it'd be hot flashes. And it was theorized that a stellate ganglion block would actually help with the perception of hot flashes. So researchers took 40 women. 20 women got the actual stellate ganglion block, and the other 20 women got a sham block, creating a control. And they found that there was no difference in the frequency of hot flashes. But there was a reduction in frequency of very severe hot flashes in the group that actually received the stellate ganglion block. These following therapies do show some inconsistent evidence. We're talking about the plant-based phytoestrogens such as soy, red clover, isoflavones, and most of the trials showed a very small benefit over placebo. Some didn't have placebo. There was a lot of meta-analysis, and overall, the reduction in hot flash frequency was small, and it wasn't really clinically meaningful, or it may not be very meaningful to individual patients. In one meta-analysis, they found that the maximum reduction in frequency of hot flashes was 1 hot flash per day. For breast cancer, dietary soy did appear to be safe and reasonable. However, this is not equivalent to the supplemental highly concentrated isoflavone soy in powders and pills, and those are to be avoided for now as long-term research regarding these products are limited in terms of patients who have ER positive receptive breast cancer. Black cohosh has been very popular, but despite all that fame, large reviews showed no benefit over placebo, which meant that both groups reported a benefit, but it wasn't statistically significant. There is no clear link to breast cancer recurrence at this time. Randomized controlled meta-analysis did not show consistent adverse effects of black cohosh on liver enzymes, but there have been some reported cases of liver injury. So if you have pre-existing liver disease, or if you develop liver injury, then black cohosh consumption must be stopped. Acupuncture was found to actually be better than no treatment at all, but it wasn't better than sham acupuncture. Obesity increases hot flash risk, and in one study, participants who had a weight loss improvement actually had a similar improvement in their hot flashes. This was more pronounced in women who had bothersome hot flashes at baseline. This is one of those few lifestyle interventions that actually showed real promise and improvement. The following are currently ineffective therapies. These have not been shown to work better than placebo: evening primrose oil, flaxseed, exercise. We're going to talk about that. Ginseng, dongquai, wild yam or progesterone creams, reflexology, magnets, and Chinese medicinal herbs. Exercise is always to be emphasized. 30 minutes a day of moderate intensity physical activity for 5 days a week to get 150. But it didn't show to improve hot flashes. Here are our final takeaways. Cognitive behavioral therapy helps insomnia and coping, even if the hot flashes persisted. Hypnosis and stellate ganglion blocks are promising, but experimental. Most supplements do not outperform placebo. Dietary soy is not equal to supplemental soy, even breast cancer. The placebo effect is powerful, but that doesn't mean that the symptoms are made up. Hormone therapy continues to remain the first-line drug class for physicians when trying to treat patients with very severe menopausal symptoms. But we are fully cognizant that not every woman can take hormones or even chooses to do so. This is where these alternative therapies can play a role. In a previous video, I talked about other medication classes, just SSRIs, SNRIs, oxybutynin, and the like that may also have a role. So there are quite a few options. If you like this content, give me a thumbs up and subscribe. I'm here to make the medicine make sense. So stick with me. Until next time.